It's a pleasure for me to talk about understanding the mechanisms of hypertension. I will speak to you, of course, as a cardiologist, perhaps looking from a different role. So I think what is important from the cardiac point of view is that afterload stress on the heart will meet a multiple hit hypothesis, leading in the end also to heart failure. So it is important to realize why these patients develop hypertension and how to treat them and actually to treat them as we have already seen. As you all know, of course, the incidence of hypertension is actually quite high, also with the newer VEGF inhibitors, and it seems to be a class effect. So several risk factors have been identified leading and influencing to hypertension and or cardiac toxicity. And of course, it is pre-existing hypertension which is encountered in many patients or pre-existing cardiac disease, which is of course an important role for patients developing this side effect. Many possible mechanisms of hypertension have been identified, and I will just go through some of these, which to me appeared to be among the most important. Of course, there is angiogenesis inhibition, and rarefication of capillaries has been discussed. Inhibition of NO synthesis has been repeatedly shown to play a role. Prostacyclin production is decreased, and of course oxygen radicals may be increased, leading to endothelial dysfunction. And lately there has been a lot of discussion about neurohormones and endothelin activation. And of course, renal impairment with proteinuria leading to preeclampsia has been shown, and also the inhibition of other kinases, platelet-derived factors, and the influence on thyroid function, as we have just heard very nicely, plays an important role. So let me start with rarefication in VEGF inhibition. It has been shown that there is a mean dermal capillary density reduction in experimental work looking at microscopic histology, and there was a reduced vasodilatory response as a marker of reduced endothelial function. And this has been shown repeatedly with different therapies. And furthermore, the capillary structure showed apoptosis of the endothelial cells. Again, this, however, appears to be a more chronic process rather than an acute process. And although there are several factors speaking for the capillary rarefication, when we look at the literature, I think it is more a chronic process because there is already an early blood pressure rise on the very first day in, for example, sunitinib in rats or also in patients. You can see this. And this might more point to an NO decrease or other mechanisms such as endothelin increase. And actually, when they did a mathematical model looking at this, you will see that you need a high reduction of arterioles to come up with a 5% increase of resistance in the vascular bed. And also, I think this is very important that untreated hypertension itself will lead to a decreased organ perfusion and a remodeling of the small arteries, which can be reversed after therapy. So I think it is unlikely as a sole cause of hypertension in this setting. The role of the NO pathway, I think, is an important part also here because there is the endothelial-dependent NO pathway responsible for the vasomotor tone, and also the central neural-dependent central sympathetic vasoconstriction pathway. And importantly, NO, nitric oxide, is an antagonist to angiotensin II and also to endothelin-1. And sorry about that. And this has been shown that if you inhibit the endothelial growth factors, you will see a rapid change in blood pressure already in the early initiation of therapy. But there are, of course, again, contradictory results. So when we look at the blood pressure monitoring in patients, we will see that in normotensives, but even more in hypertensive patients, especially older patients or patients with previous hypertension, we will see a quite tremendous increase with sunitinib. And I think this is very interesting, a reflectory decrease in heart rate. And when you pause the therapy, there is a decrease again, which after resumal of sunitinib, you will have an increase again. And of course, we will give these patients antihypertensive treatment. And as we have seen just very nicely, this is not, if we treat this, it's not associated with a poor survival. Recently, there have been several very interesting experimental research studies showing that hypertension is associated with increased circulating endothelin-1. And this has also been shown in cardiac disease. Endothelin-1 is always consistently associated with hypertension. There was actually an increase twofold in endothelin-1 that you could measure in the plasma. However, there was a decrease in plasma renin and no change in aldosterone, and importantly, also no change in the plasma catecholamines. So when they looked at patients again with sunitinib, you see again the rising in systolic and diastolic blood pressure. And I think very important also from a cardiac risk standpoint, there is a lack of circadian rhythm, so there is no nocturnal dipping found under treatment. And again, the heart rate decreases a little bit. So the endothelin increase leads to hypertension and also affects the renal impairment with proteinuria. And there was an increase in creatinine and protein excretion in these patients, and also in rats, in this rat model here again. And they found a significant threefold increase of circulating endothelin, and also interesting of BNP, which is always a marker of cardiac wall stress, which is increased. So when they looked at the histology of these kidneys, they found that there was glomerular shrinkage, and this goes along with the creatinine increase and the proteinuria, which is only part of a reversal after a stop of sunitinib. So endothelin has now been named, is it really the smoking gun in all of these different mechanisms, NO and the renal changes, endothelial dysfunction, and of course the angiogenesis and angiotensin itself. And when they looked at this further here, this group from Netherlands, from Kappes and Mayraker, they found again that although renin is suppressed, the endothelin is raised, and there is also an increased urine excretion of endothelin. However, the site of endothelin production remains somewhat unclear. It appears to be expressed in the kidney itself and in the vascular endothelium. But there may also be a reduced clearance mediated by the ETB receptor. However, and I think this is a very important and very interesting clinical point, that there is a reversal repeatedly seen of hypertension if you give an endothelin antagonist. So endothelin induces hypertension, we mentioned this already, and I think the important point is that maybe we are not measuring endothelin in the plasma is not such a good measurement. Maybe we should be measuring proforms such as peak endothelin and C-terminal endothelin, because it is an abluminal paracrine local production of endothelin in the endothelium. Finally, this group also showed that, again, if you look at the kidney, you have a preeclampsia-like syndrome, because also in preeclampsia you see rising of endothelin levels, And just very recently, they looked at a swine model, and they came to the conclusion that the vasoconstriction is selectively seen in the systemic vascular bed, and importantly, not in the pulmonary or coronary circulation. It does not lead to a pulmonary hypertension. And again, it was well reversed by endothelin antagonists. So, although there was no change in plasma catecholamines and a decrease in renin, I think it is important that ACE inhibitors and beta blockers, as we have already seen, are very effective actually in the treatment of hypertension. And as we have seen already, it's an efficacy marker. But I want to point out that it appears that antihypertensive therapy had no negative effect on survival, and actually the angiotensin system has been shown to improve. If we inhibit the angiotensin system, it has been shown to improve the outcome of patients with sunitinib. However, this was a retrospective study. And I think this will be a very important point to understand in the future, because angiotensin 2, as coming here from the group of Dr. Aparicio, has multiple roles, which if we inhibit this cascade, we can expect different mechanisms and effects. And I will wrap it up very quickly. Captopril has been shown to reduce hypertension and to improve the glomerular injury and tubular casts. They were well reduced by the ACE inhibitor. This is a very old ACE inhibitor, and you can see this in rats. And so I think it is very important to manage the hypertension in TKI. We can give ACE inhibitors, beta blockers, carvedilol, which probably also has different antioxidant properties. And I think nebivolol could be very interesting because it is an NO donator in these patients, and I think there's a lot of questions still open. One point I just want to point out is that we should avoid verapamil because of the inhibition of CYP3A4, and there are many, many open questions, and I think all antihypertensives are actually allowed, but we have to check creatinine and potassium, and the aim for us as cardiologists working together with the oncologists is to continue the anti-cancer therapy with our cardiologic and antihypertensive treatment. So in conclusion, I think my take-home message is perhaps that endothelin is popping up as a new kid on the block. Endothelial activation is a major pathway in these patients, and there might actually be a very interesting future role of endothelial antagonists in this treatment field. Thank you very much for your attention.